Good afternoon, everyone. Oh, and you can take your mask off while you're.
Oh, okay. Thank you.
Good afternoon, everyone. Welcome to week 3 of Summer Core Lecture Series.
I have a chatty group.
Hi, guys. So let's welcome Dr. Vellanki. Dr. Vellanki is one of our nephrologists, and she's going to be giving us a lecture today on acute kidney injury.
Thank you. Hi, everyone. Good afternoon. So you'll be meeting me while rounding on the renal consult service. So welcome on board. And we're going to talk about acute kidney injury today. I'm going to start off with a case. I'm going to do the talk as, say, how do I approach a patient who has acute kidney injury? So we'll be back and forth going from the case and talking about it. Feel free to stop me if you have any questions in between. So the case is a 60-year-old female with diabetes and hypothyroidism admitted to the hospital as routine labs showed hyperkalemia and a serum creatinine of 5.6, and renal service was consulted for further evaluation. She was treated in the last 2 months for pneumonia with various agents. She was initially on cefuroxime and livaquin for almost 3 weeks, and then she was switched to Unison and Vanco 4 weeks prior to the presentation. Since there has been no response to treatment, she was transferred to Loyola 3 weeks prior to the current presentation for necrotizing pneumonia and parapneumonic effusion. She was discharged home 2 weeks prior to presentation with outpatient follow-up with various physicians for the above. And as you read through the case, most of the renal consults you get are going to have a detailed prior history because you get called on in-hospital patients who develop AKI as well. So most of the time you're doing a thorough chart review because the patient may not always give you that history. On review of systems, she had positive fatigue, poor appetite. There was subjective decrease in urine output despite her taking Lasix since her last discharge, and she also reports swelling in her legs. No pertinent family history of kidney problems that she's aware of. No over-the-counter medication use. She's had enough medications prescribed that she didn't need any over-the-counter medicines. And as I mentioned, about antibiotics and Lasix, allergies to codeine. And on presentation, she's hemodynamically stable, blood pressure is good, pulse of 88, afebrile, oxygenating well on room air. And on physical exam, she did have some bibasilar crackles. She did have some pitting pedal edema bilaterally. Other than that, nothing significant. Okay. So, and these are her labs. The reason why renal was consulted is, and you can see everything in yellow, right? She's hyponatremic, she's hyperkalemic, her BUN is high, creatinine is 5.61, calcium is slightly low. And although your lab gives you an estimated GFR, keep in mind the formulae that we use to measure GFR are for a steady state patient. They don't mean anything in a patient who's coming in with an AKI. So even though they give you a GFR or 8 or 9, the patient could have lower than that. So how do you define acute kidney injury, right? So previously, we didn't have a good definition, meaning people used to use various terminology, raise in creatinine by 0.3 or raise in creatinine by 0.5 or decrease in GFR by 25, 30, 50. So there used to be various cutoff points used. And unfortunately, when you had to compare clinical outcomes and compare various clinical studies, the definition of AKI varied in each clinical study. So it was always tough to compare outcomes. So there was need to come up with a uniform criteria. And if you remember, I don't know how many of you were in medical school when the terminology of acute renal failure, we still use it. Acute renal failure is still used. And the problem with renal failure, acute renal failure being every raise in creatinine doesn't mean the kidneys are in failure. So came up with the new term, acute kidney injury. It has its own pros and cons. Like every other definition, it's not perfect. So increase in serum creatinine by greater than 0.3 milligram deciliter within a 48-hour period, or increase in serum creatinine greater than 1.5 times the baseline that has so if you have prior labs and you compare it, a 0.3 raise in serum creatinine or 1.5 times baseline, if you know the labs 1 week prior to presentation, or there's a decrease in urine volume by less than 0.5 liters per kilo per hour for more than 6 hours. And these diagnostic criteria should only be applied after volume status has been optimized. Unfortunately, in clinical practice, any rise in serum creatinine, we call it as AKI in the current circumstances, just because for billing purposes, any rise in creatinine is considered AKI. You don't have a different terminology to use. But keep in mind is you're ruling out volume depletion if you're looking at a true AKI. And then if you're taking urinary volume into consideration, you have to rule out obstruction, right? So you can use this criteria after you volume replete the patient and you ruled out obstruction. The problem is there could be a lab variation in creatinine. There are a lot of substances that can affect creatinine measurement. So you're not just looking at raise in 0.3, you're also making sure that there's a consistent rise. You're not just looking at one lab value and you see a 0.3, you're automatically terming it as AKI. As I said, lab itself is not perfect. I've had many patients who get labs the same day or has BMP checked at the same time, and you can get two different values that can vary by 0.3. Number two is if you have a CKD patient, a 0.3, if a patient's baseline serum creatinine is 3.5, say for instance, and you do labs today and it's 3.9, GFR is still almost the same. So you have to keep all of that in mind. A 0.3 doesn't apply for patients with CKD. Probably better appropriate term will be as a decrease in GFR by 25, by more than 25%, but I'm contradicting myself because I said, hey, you can't use the formula for calculating GFR in a patient who has AKI. That said, take the overall clinical picture into consideration and not just one lab value when you're assessing a patient. So coming back to a patient, right? So remember, we are lucky in many of these patients, you have hospitalized values, you have daily labs. In some patients, prior hospitalization, you have those values, but there may be patients walking in with a creatinine of 4 or 5 and you don't have prior labs to compare. So you're making an educated guess in those patients whether this is acute or chronic. So for our patient, we were lucky. We had labs from prior admission. She was hyponatremic all during that prior hospitalization, and this was 10 days prior to her current presentation almost. You can see that her creatinine was 1.2 and right at the time of discharge was slightly creeping up, right? But you do have prior values to compare that her kidney function is abnormal compared to 10 days ago. So how do you come up with a differential diagnosis? Again, despite the terminology changing, the structure of kidney remains the same, the anatomy remains the same, right? So your pre-renal, intrinsic, and post-renal, they remain the same. So coming to what helps you in differentiating based on your H&P so far. So if you're looking for history, you're looking for any history suggestive of volume depletion, any nausea, any vomiting, any diarrhea, any poor oral intake, and then any blood loss. You're also looking for any recent hospitalizations that they may have had, any medications prescribed, any over-the-counter medication, any imaging studies, Did the patient have any recent invasive procedures? We just had a patient who had 20 liters of fluid taken out during paracensis as an outpatient, which is pertinent when he comes in with an AKI, right? So those are all some things you look in history. And when you're looking at family history, you're looking at pertinent issues related to the kidney, like is there any family history of polycystic kidney disease? Is there any family history of glomerulonephritis like FSGS? They can be familiar. Diabetic nephropathy can run in families. Or if they have parents predisposed to diabetic nephropathy, the chances of the kids or the siblings having it is higher. Then you look at their vitals. On presentation, were the vitals stable or unstable? You look at physical exam and look for any signs of volume depletion or volume overload. It could be tough to differentiate volume depletion in your cirrhotic patients or your heart failure patients. How many times I've seen a right heart failure patient, florid right heart failure, but I look at them and they look euvolemic. And you get right heart cath findings and you see pulmonary capillary pressure really high. So some of those patients, you may not be able to assess the intravascular volume status just based on your physical, but most of these patients, you can make an educated guess by doing a detailed physical exam. And you look for any rashes, you see if there's any joint pains, joint swelling, any of that stuff involved, any suprapubic tenderness, any suprapubic fullness, to see if there's any urinary retention. Again, it may be tough for you to elicit this in morbidly obese patients or patients who have cirrhosis. Suprapubic fullness may be tough to elicit. So then you figure out, is there obstruction in your etiology? You have mostly, say you have elderly patients coming in, obstruction is something you need to think of. And can you rule out obstruction based on your physical exam? If not, do you need any imaging studies to rule out obstruction, right? I always say this, the highest serum creatinine, one of the highest serum creatinine I've seen is a creatinine of 40. And we were actually called because the patient's potassium was 7.2. And he just needed a Foley. He had a huge bladder and no symptoms. You talk to the patient, any trouble peeing? He's like, no, he just came in for weakness. And he just needed a Foley, and guess what his creatinine a week later was 0.8. And I've had patients walk into the clinic for CKD evaluation, just got an ultrasound done, and it shows bilateral hydro. So it's tough to elicit, get a good history in obstructive uropathy. It's something easy to fix, and something I'll hate myself if I put a patient coming in with obstruction, I didn't do an ultrasound and put him on dialysis for hyperkalemia, right? Because it's not going to cure his obstruction. So I always say this is Foley before a Quinton catheter placement. And you probably already realized by now is Isonose are the toughest to get in hospitalized patients. It's easier to get a cardiac cath, it's easier to get a CT scan, but you'll never get an accurate Isonose for hospitalized patients unless they have a Foley, and you don't want to put in a Foley in every patient because there's a risk of UTI. Right? But say if a patient has decent amount of urine output, you do have a differential diagnosis for patient coming in shock or something. It's not necessary for you to go ahead and do an ultrasound right away. And keep in mind, if patient is coming with shock or coming in with volume depletion, severe volume depletion, even if the patient has obstruction, underlying obstruction, you may miss on the initial imaging because the patient is not making any urine. So you won't have any hydronephrosis or backup of urine. And sometimes you may notice that after repeat imaging, you hydrate the patient is now volume repleted, urinating and repeat an ultrasound. You may see a hydro now that was in there before. Doesn't mean he developed obstruction now. It could be that you didn't find it in the prior imaging just because he wasn't making a urine. So coming back to a patient, she did have ultrasound of the kidneys and kidneys looked okay. So whenever you're looking at kidney size, so one of the things that will help you differentiate whether this is CKD or AKI is looking at kidney size on the kidneys, on the ultrasound. And kidney size is proportionate to the vertebral height. So if there's a taller person in this class, probably will have bigger kidneys compared to me. So this patient had 11 normal size kidney bilaterally. There was some increased renal echogenicity, which again could suggest scarring, but also keep in mind, it could also suggest active inflammation. Patients who have GN, the initial ultrasound report can come up as increased echogenicity of the kidneys. And no hydronephrosis, right? So you ruled out obstruction. So how about UA and urine indices, right? This is her urine. Hazy. She had 2+ protein, large blood. She has leukocyte, she has RBC, she has WBC in urine. Where can you see such urine? Can she have an infection? Yeah, right? If a patient has UTI, a UA can look like this. So you make sure when you have a UA like this to rule out a urinary tract infection, because urine can look abnormal. And these are her urine indices. Her fractional excretion of sodium, which we'll talk about later, came back as 4.1. Fractional excretion of urea was high. She did have a few eosinophils on the smear as well. So far, based on what I provided to you, we ruled out post-obstructive uropathy, right? You had an ultrasound that's ruled out obstruction. Based on a presentation, can you rule out pre-renal? Yes, no? What would you expect if she came with a 129 sodium and a creatinine of 5.6? If this is pre-renal, what are some of the physical findings you would have expected? Yeah, you could see edema, right? If it's heart failure patient or a cirrhotic patient, you can see edema. What else? She's not hypotensive. She's not tachycardic. She didn't have distended neck veins. Her lung exam was clear. So unlikely pre-renal, right? Yes, take out that florid right heart failure patient I was talking about, but they do have cardiac history. This patient didn't even have cardiac history. So those are all the things when you're evaluating a patient for AKI is looking at is, okay, based on the history and physical, can I rule some of the etiologies out? Based on what information we have so far, unlikely that she has pre-renal etiology because she was stable hemodynamically, no signs of volume overload. She did have some edema, but that edema could be a result of renal failure rather than renal failure, the edema causing the renal failure in her, right? So how would your pre-renal urine indices look? This is how, if this patient came in with pre-renal, this is how your urine looks, completely bland. And you look at the fractional excretion of sodium, urine sodium is going to be pretty low. Urine chloride is a better marker than urine sodium in some of these patients, and it's going to be low. Your urine creatinine is going to be high. When you see this urine, which is bland, I always say is kidney is just trying to say, I'm not at fault, look somewhere else. I'm just reacting to something going on in my body, but I am not the primary culprit. Okay. So no matter patient has lupus, sepsis, whatever going on, she may have markers of inflammation, something inflammatory process going on. Urine looks like this. It's not the kidney's fault. Kidney is reacting to something going on in the body. Now it's your job to figure out, okay, why is the kidney reacting the way it is? It could be volume depletion, but it could also be florid heart failure. And your urine is not going to give you that information. It's just going to say, okay, the tubules are intact, and your physical exam and your history and all of that is going to play a role in coming up with a differential diagnosis. Okay. So now talking about the most famous or infamous urine indices and how do you interpret pre-renal versus intrinsic? How do you differentiate based on urine indices? There's lots of ifs and buts of urine indices. Keep in mind is kidney is not static, right? Your kidney function, the amount of urine you produce, the consistency of the urine varies minute to minute, varies hour to hour, depending on your body needs. Now, I didn't have my lunch. I didn't have a big breakfast. So you check my fractional excretion of sodium, it's going to be low. For people who are eating your lunch, if they check your fractional excretion of sodium, it's going to be high after you eat your lunch, right? And so kidney is going to excrete the amount of sodium or other substances depending on your body needs and what body metabolic needs, what you put in. The problem with all your urine indices when you're checking in, the ideal time to check the urine indices is when the patient presents to the ER. By the time you see the patient got 3 liters, 4 liters, 5 liters of volume resuscitation or started on pressors, something else. The initial evaluation has already been done. And I don't expect the ER physician to wait for the urine studies to start treatment of sepsis or volume depletion. That's not the right way. You go ahead and address the patient right away. Just keep in mind that while you're interpreting the urine indices, you have to keep all of this in mind as well. Yes, you will get information about more than how much sodium is the kidney excreting. When I'm looking at urine indices, my major thing is, okay, is there something going on in the kidney or is the kidney reacting to something else? And your urine indices give you the same information as well. When you look at in pre-renal state, right, whenever the kidney perceives that there is low volume for whatever reason, kidney will try to reabsorb as much as water and sodium as possible and conserve the volume because that's what the kidney is supposed to do. So it's an appropriate response from the kidney standpoint. So you will have a specific gravity that's going to be high. Your urine osmolality is going to be high. Since sodium is being reabsorbed, your urine sodium is going to be low. Fractional excretion of sodium, which is the amount of sodium excreted per nephron, is going to be low. Fractional excretion of urea. Urea passively follows water and sodium reabsorption. So urea gets reabsorbed as well. So the amount of urea in urine is low. So your fractional excretion of urea in urine is going to be low. This may be better marker than your fractional excretion of sodium in patients who are on diuretics, because patients who are on diuretics can have a high sodium, urinary sodium, fractional excretion of sodium. You look at urine creatinine, it's going to be high in pre-renal. Remember, whenever we talk about creatinine clearance, we say that creatinine clearance is not a good estimate, it's a overestimate because creatinine gets secreted in the proximal tubule. So whatever creatinine you see in the urine comes from GFR and comes from tubular secretion. So in a pre-renal state, your patient has intact tubules. So urine creatinine is going to be high. You check a urine to plasma creatinine ratio, it's going to be really high. Give you an example, look here. Look at this urine creatinine, 205. So generally when I see a urine creatinine 190s, 200s, 250s, I know the patient's tubular function is intact. And because BUN gets reabsorbed, the serum BUN to creatinine ratio is going to be greater than 20:1. There's something called furosemide stress test, we'll talk later on, which you can check to see if this is pre-renal versus intrinsic, because sometimes you can make the decision based on urine indices, and sometimes the UA may look abnormal because the patient has Foley in place, can have blood, can have, if a patient has hematuria, can also have protein in there from the blood. So what do all the pre-renal urine indices tell me? That the patient has intact tubular function. It doesn't give me the etiology of AKI. It just tells me that in this patient, those tubules are intact. When you see the opposite, when the patient has dilute urine, patient losing lot of sodium in urine, or fractional excretion of urea is high, urine creatinine is low, in your BUN and creatinine ratio is low again, less than 10:1, it again tells me in that patient, those tubules are impaired. And this is where intrinsic is where we use the term acute kidney injury, because that's where we suspect tubular injury. So these are the urine indices that you look in a patient who has an AKI or acute kidney injury. Okay. And this is just saying is because tubules are injured, your sodium and urea reabsorption and creatinine secretion is impaired. As a result, your urea is high, so your fractional excretion of urea is high. Your urine creatinine is low. Serum BUN and BUN is low, and BUN to creatinine ratio is low as well. If you understand the concept, all of it you'll understand it. You don't need to know the exact values of all of this. Just understand the concept of why do these patients in pre-renal state have low fractional excretion of urea or low FeNO. If you get that, it'll be easy to remember rather than remembering the actual values. Okay. So what happens in pre-renal state? When you give them Lasix or when you give them high dose furosemide, loop diuretic, why does the urine output increase? Right? So where do your loop diuretics work? Loop of Henle, good. Okay. And how do they get there? When you give Lasix to a patient, how does it get to the ascending loop of Henle? It gets transported to the proximal tubule and then goes through the ascending limb and works on your sodium potassium 2 chloride. So for a patient to respond to Lasix, the tubular function should be intact, right? So in a patient who has acute tubular dysfunction from whatever etiology that is, you don't have the Lasix doesn't get transported to the ascending limb, so it doesn't work. But in a pre-renal state, the patient has intact tubules. So if you give them and the patient is hemodynamically stable, say if a patient is in shock, no matter how much Lasix you give, they're not going to respond because there's severe vasoconstriction. So in an otherwise hemodynamically stable patient, in a patient who has persistent oliguria, if you give a single dose of high dose Lasix, when I'm not 20 or 40, we are talking about 100, 120, it's like 1 to 1.5 milligram per kilo dosing. You can see up to 200 ml increase in urine output over the next 4 hours. So and as I said, this should be in a euvolemic patient. We're not taking a patient who's in volume depletion or something else because the kidney is going to respond to that than to the Lasix. So that means in these patients, the tubules are intact. And these are the patients that there's a high chance of renal recovery. Okay, this is just giving you the patients who responded to Lasix versus those that didn't respond to Lasix and what happened during the clinical course. And it works good. How good is a furosemide stress test compared to the lot of urinary, how should I put it, markers that could be used as tubular injury, urinary NGAL being one of them. And as I said, there are a lot of others. How well does furosemide stress test work compare? It works pretty good. It is comparable to all other urinary markers that's out there. And when you look at whether the patient needs dialysis during that hospitalization or not, it's comparable. It beats most of the others. And I'll give you an example. I think I come back to the patient. I didn't realize that this is the same patient, but this is the patient who actually got the 20 liters paracensus and came in with oliguric AKI. He actually was transferred from outside hospital. He had a quintin in place because he's oliguric. And these are his urine indices. When he came to Lila, we checked the urine indices. Sodium is 14, chloride is low, creatinine is high. Right? I don't need to calculate a fractional excretion of sodium because it's going to be pretty low. So we said, fine, he doesn't need, based on these numbers, he didn't need emergent dialysis at that time. We said, okay, give him Lasix. He has pre-renal urine indices. He should be responding to Lasix. And this is what happened. And he's hemodynamically stable. That's the main thing, is he's not on any pressors, he's hemodynamically stable, just intubated. Day one, he was 10, and he was put on 100 milligrams IV BID Lasix, and you see he did respond. All I'm trying to say is this patient didn't need dialysis. His renal function eventually recovered, and look at the urine output he made. And even after taking off Lasix, he was still peeing. So Lasix is not going to help the renal recovery unless you're talking about cardiorenal, where there's volume overload playing a role. Otherwise, you're just converting a non-oliguric patient to non-oliguric, and it can help you in volume management. I don't have to dialyze the patient for volume if the patient is responding to diuretics, right? That's the only thing. Otherwise, it's not going to make the kidney function better soon. Got that? Okay. So coming back to a case, based on the information we have so far, we ruled out pre-renal, we ruled out post-renal. Now, what's the etiology of her AKI? Could be various, right? She was treated for pneumonia. She was on various antibiotics that could have affected her kidney function. And as I told you, urine eosinophils were positive on the smear, although they don't mean anything in this day and age. Back in the day, they used urine eosinophils were used to make a diagnosis of acute interstitial nephritis. So etiology is still broad in her. It could be tubular injury, it could be acute interstitial nephritis, it could still be GN because she could have post-infectious GN. So how do you differentiate one versus the other? It's easy again if you remember the structures that the kidney is made up of. Kidney is made up of tubules, glomeruli, interstitium, blood vessels, and the collecting system, intrarenal collecting system, right? And what's the most common in-hospital cause for AKI? I'm okay. There's a huge debate about contrast being nephrotoxic or not, so we won't even go there. But say I'm talking about the structures. What's the most common in-hospital cause? ATN. Good. So acute tubular necrosis, although the term is used as acute tubular necrosis, it's rare that we see necrosis. So it's actually acute tubular injury rather than necrosis. But since it's termed as ATN, we still use that term. So when you're looking at ATN, what are some of the causes, right? Ischemic versus, again, easier for you to remember if you consider it as ischemic. Any prolonged pre-renal state can lead to ATN. How long is too long? I can't give you a definite answer for that. It depends on the patient's comorbid conditions, what's going on during hospitalization. Heart failure patients stay in a prolonged pre-renal state compared to any other pre-renal, and we still have to yet to identify why heart failure patients are different. When you look at toxic, either it's exogenous, something you're giving to the patient, or endogenous, something the body is producing in excess. Exogenous, a patient got vancomycin, right? You said contrast. So it could be antibiotics, could be antiviral agents, could be antifungal agents, cancer drugs, contrast, any high osmotic agent, mannitol. Now contrast, I know there's been a lot of debate whether contrast is nephrotoxic or not. In you and me, in a steady person, unlikely for contrast to cause AKI. But the hospitalized patients that we see, right, they're sick enough to be in a hospital. So those are the ones who are at increased risk of contrast-induced nephropathy than the regular outpatients that you see. So it may be an overkill for you to not do a contrast study in a steady outpatient just based on the creatinine. But for a hospitalized patient, still think about contrast-induced nephropathy. How many times do we see patients getting contrast and then you see a rise in creatinine 48 hours later in the hospitalized patients? So I think the argument is contrast per se may not be nephrotoxic, but in certain circumstances, it may be. But the question is, if you can avoid giving contrast to a patient, avoid it. Do a non-contrast study and do contrast in those patients that really need them. So something the body produces in excess, right? Myoglobin in rhabdo. If you're doing hem-onc rotation, tumor lysis syndrome in the cancer patients, myeloma patients can develop light chain nephropathy, which is light chains are tubulotoxic, and massive hemolysis, massive intravascular hemolysis, release of hemoglobin. Hemoglobin, similar to your myoglobin, can be tubulotoxic. Similarly, I don't have it. High levels of bilirubin in your liver patients can also be tubulotoxic. Okay. How about acute GN, right? Generally, these patients present with unexplained renal failure. They can be hypertensive, but they can also be normotensive. They have subnephrotic range proteinuria. So generally, the protein is less than 3.5 grams. But some of them can have a little bit more proteinuria depending on how bad the underlying process is. And you look at the UA, it'll be similar to this. When I showed you, the patient can have blood, can have protein, can have WBC, can have RBC. You spin the urine, you can see RBC casts. So these are, you rule out infection and the UA looks like that, think of glomerulonephritis. Okay. So that's where we call urine is active. And you need to figure out what's going on with the kidney. And in these patients, kidney biopsy, you need a kidney biopsy for definitive diagnosis. And you can start the initial workup as you can, if post-rep GN or lupus, you can check complements, you can check ANA, you can check ANCA in appropriate patients. The most common GN in elderly patients is ANCA vasculitis. So you have that presentation, consider ANCA vasculitis. Anti-GBM, I've seen maybe 1 or 2 cases, not 1 case in my 10 years here. IgA nephropathy, these patients present with gross hematuria. So, but you can start the initial workup. But as I said, ultimately the patient needs a kidney biopsy. How about acute interstitial nephritis? Right? Our patient got cephalosporin. So she could have AAN for all I know. So their medications, the reason methicillin is not used for MSSA bacteremia anymore is because of the high incidence of acute interstitial nephritis. I think when it was being used, AAN was reported to be as high as 1/3 of the patients had AAN. Bacterem can cause it. Quinolone's a common culprit as well. PPIs, how many of our patients, we put them on Protonix and forget to take it off? Sarcoidosis, chronic inflammatory states like sarcoidosis or underlying infections can cause interstitial nephritis. Your medicine boards love this condition called TINU. It's interstitial nephritis and uveitis. If you have a patient presenting with red eye, blurred vision, and has acute renal failure, think about interstitial nephritis. And these patients, the classic triad that the textbook describe of fever, rash, and peripheral eosinophilia is seen in less than 10% of the cases. Urine eosinophils, neither sensitive nor specific. So just because a patient had urine eosinophils doesn't mean she has interstitial nephritis. So it's not neither specific, and absence of it doesn't rule out interstitial nephritis either. One thing you can look out for these patients is they can have sterile pyuria. They can have WBC in urine, but the urine culture can be negative. Again, these patients need kidney biopsy for definitive diagnosis. Sometimes you may hold the medication or whatever the culprit and you can see an improvement in creatinine. When I'm talking about blood vessels, I'm mainly talking about TTP, HUS, malignant hypertension, scleroderma renal crisis, preeclampsia, thromboembolic diseases. The problem with all of these like TTP, HUS, malignant hypertension, scleroderma, renal crisis is kidney biopsy can look similar. And so you're relying on, you have overlapping features because scleroderma patients can present with malignant hypertension, right? Lupus patients can present with TTP and malignant hypertension, and patients with TTP can have uncontrolled blood pressure. So you can't rely just on the clinical features to differentiate. Something that can help you is if a patient has papilledema and presenting with uncontrolled blood pressure, it's malignant hypertension until proven otherwise. And those are the patients where you're going to treat the blood pressure rather than do a plasma exchange. Okay. And pyelonephritis, always say this, I don't know where to put this, so I put it here, but patients present with fever, flank pain, dysuria, your WBC, your patients will have positive blood and urine cultures can be positive. They'll have WBC in urine, and these patients can have WBC CAS. Your interstitial, acute interstitial nephritis too, you can sometimes see WBC CAS, but the cultures are negative. And treatment in these patients is fluids and antibiotics. Okay, so coming back to a case again, what is in your differential? Does she have TTP HUS based on the information I gave you? Unlikely, right? Her platelet count was stable. I didn't show you that, but I showed you that earlier, but we didn't. Okay, how about pyelonephritis? She doesn't have any of those features on presentation. How about interstitial nephritis? Possible, right? GN, possible. ATN. Only difference is in ATN, you generally don't see RBC, right? So she does have hematuria. You can see protein, you can see even nephrotic range proteinuria when the tubular injury is pretty bad, but it's very unlikely for you to see hematuria in ATN. So keep that in mind. You can even see a little bit of hematuria in AN, but unlikely in ATN. So back to your case. She has a non-oliguric AKI. She had 800 cc of urine presentation. She had positive blood with RBC and WBC. Initial concern was for acute GN. Initial, again, differential diagnosis was post-infectious because she was being treated for pneumonia and has all these infectious versus vasculitis. So her compliments came back. We did order compliments, ANA, anchor. Compliments came back low, and ANA was pending. Anchor takes a week. We just had a patient on service. We ordered anchor, and it's been 2 weeks. And when we called the lab, they told that the patient never had the anchor done because it's being transported out of Loyola now, and the blood leaked out of the tube. And nobody bothered to tell the team. So keep that in mind, is if you don't get anchor within a week, check with lab to see the specimen was actually being sent, but it may take up to a week for you to get the results. So it's easy to get the definitive diagnosis by kidney biopsy than waiting for the anchor, although we do need that in management of the patient. Since she had persistent hyperkalemia despite medical management, we were anticipating dialysis needs. So we said, okay, let's get a quintin and do a biopsy. And unfortunately, this patient was on surgical team. So we said, switch her to medicine service. She needs a medical team. So how do you manage AKI, right? So you volume deplete in volume, if volume, you see volume depletion, you treat heart failure, you diurese the patient if patient is coming with a heart failure exacerbation, you treat the underlying infections, you stop the offending agent. If it's obstruction, you relieve it. You have to track daily weights, blood pressure, I's and O's. Unfortunately, as I said, it's very tough. Even weights vary. You see, one day the patient is 10 kilos above her weight, and next day she's 20 kilos below. So you can't even go by that. You try to maintain adequate blood pressure as much as possible. Keep in mind, most of our patients are hypertensive at baseline. So your MAP of 60 may not be enough for them, and they may actually need higher MAPs. I know all our fellows put dose renally medications in their note, but it's tricky, right? You're basing your, again, creatinine clearance or whatever you use the creatinine, you're basing it on a BMP from the morning. It could be in the patient I showed who made 4 liters of urine output, his creatinine may be a lot lower later in the day than when you're taking your morning. So there's no ideal way of doing this. It's just we have to be highly vigilant. I've seen patients have a vancomycin of 60 with just getting 2 doses of vanco because they're in oliguric AKI. So you just have to be highly vigilant when you're dosing antibiotics because you don't want to underdose these patients as well. And then management of electrolyte abnormalities is hyperkalemia, metabolic acidosis, and hyperphosphatemia, and volume overload too. So when do you consider hemodialysis in AKI, right? So exact timing, I should take out the controversial because I think we have enough studies so far. Always has been this thought process that early dialysis is good because you're preventing the patient from reaching hyperkalemia, uremic toxins, whatnot. This thing of, okay, if we intervene sooner and take the uremic toxins out, we may benefit the patient, right? The problem with that is dialysis is an invasive procedure. You have to put in a line. Most of your patients in the ICU or thrombocytopenic have an infection risk. And on top of that, whenever we are dialyzing a patient and taking off 2 to 3 liters of fluid in a 3 to 4 hour period, remember intravascular volume is 4 to 5 liters. And I have no way to say how the patient is going to react on. We had one patient, whenever we put on the machine, she used to drop up, her pressure was 160, half an hour into dialysis, not even taking off fluid, her pressure used to drop to 90, an RRT call, and she used to pass out. So it's an invasive procedure and patients can be predisposed to arrhythmias. Patients can become hypotensive, can pass out. So I always say is dialysis is the best available stress test for the heart. If a patient's heart can tolerate 4 liters fluid removal in a 3 to 4 hour period, I think that's a pretty decent heart, right? I don't know if I'm put on dialysis and you try to take off 4 liters, if I'll be able, euvolemic patient can. So the bigger question is, how do you determine the timing of dialysis? It's going to depend on the patient. Each individual patient is different. So one of the things you keep in mind is reversibility. If a patient is grossly volume depleted and comes in, if he's hyperkalemic, you replete the volume and see if they respond to your medical management, if there's any urine output or not. Obstruction, you relieve the obstruction. So you're taking all of that into consideration when you're saying, okay, do I need to initiate dialysis for this patient or not? I see a rhabdo patient coming with CPK greater than 100, not making any urine. I know this kidney is going to take weeks to recover. And there's no point in waiting for the kidney to recover because it's not going to happen right away. And that patient will need dialysis. Compared to a patient coming in with florid heart failure, volume depletion, I know that if I give them volume, they may turn the corner. And too late may, as I said, this early may be too late for some people and late may be too early for some people. And there are multiple studies. I know the couple of studies said maybe early dialysis is better, but most of the studies, timing of dialysis didn't affect outcomes. And in those patients that got early dialysis, when you compare to the late dialysis group, there were more renal recoveries in the late dialysis group. Makes sense, right? Because you're just waiting to see if the kidney recovers or not. So your age-old AEIOU still stands to date when you're considering dialysis in patients. Metabolic acidosis refractory to medical management. That said, severe lactic acidosis from septic shock, no matter how much dialysis you're going to provide to the patient, the prognosis is going to depend on how the patient responds to your septic shock management, not whether I dialyze the patient or not. Severe hyperkalemia refractory to medical management. I don't know if anyone of you were in the ICU last couple of weeks. I think we had a couple of patients with severe hyperkalemia bradycardia, right? And those are the patients you put on the machine, you see the blood pressure, heart rate go up while you're dialyzing them. Toxins, they are dialyzable. Again, you have to look at whether the drug can be dialyzable or not. Salicylates, lithium, isopropyl, all your alcohol toxicity. And coumadin can be dialyzed. That's one of the questions I got. Can INR be dialyzed? No. Coumadin toxicity, you still have to treat with vitamin K. Volume overload not responding to treatment, and uremia. Uremia is a favorite term whenever you see a patient who is altered mental status, it's a toxic metabolic, and you see a urea high, you automatically blame the urea. Unfortunately, there's no number. I've seen 300 patient with a BUN of 300 sitting, talking, doing fine. I've seen a urea 80 and you dialyze the patient and the patient's mental status does improve, saying maybe this is uremia. So you go by overall clinical picture than the actual number when you're treating the patient. But some of the uremic manifestations are uremic bleeding, encephalopathy, pericarditis. You rarely see uremic pericarditis in these day and age because you do dialysis sooner. You see uremic pericarditis mostly in CKD patients who declined dialysis and just were not ready for dialysis, or ESRD patients who missed dialysis for a long time or being under dialyzed for a long time. Back in the day when dialysis was not available for everyone, apparently it took 7 days. So by the time the patient developed uremic pericarditis, remember we didn't have such widespread dialysis machines or ability to do dialysis then. Patients died within a week. So prognosis depends on underlying severity. Most patients can have recovery, but complete recovery doesn't happen because they can have underlying scarring and they eventually can develop CKD. Okay, so what happened to a patient, right? If you look at her, she had this parapneumonic effusion and there was this concern whether she had pulmonary abscess. She had bilateral pleural effusion. She had that effusion tab, sent for cultures, she had a chest tube placed. We went ahead and did a kidney biopsy. It showed necrotizing and crescentric GN and pauciimmune. Pauciimmune, basically on immunofluorescence, you see nothing, no immune deposits. That's why it's called pauciimmune. And her ANCA eventually did come back positive. See, it took a week. I think she presented the Thanksgiving of 2015. We got the result back a week later that her antiproteinase 3 antibody was positive. So she was treated with plasma exchange, IV Cytaxin, steroids. She also got big dose antibiotics because there was concern about this parapneumonic effusion. Started on dialysis, eventually came off dialysis 3 months later. So whenever you're seeing AKI patients dialysis dependent, don't automatically label them as ESRD. End-stage renal disease means there's no chance of renal recovery. AKI patients do have a chance of renal recovery, so you don't label them ESRD. So subsequently, she came off dialysis. She didn't have residual stage 5 CKD. She was subsequently transitioned to Imuran steroids. Lung lesion completely resolved. We got a chest X-ray 3 months later. No, lungs were completely fine. So eventually, she did get a living unrelated kidney transplant in 2019, and she's doing good. This is just saying that since that case in 2015, we now have enough data saying plasma exchange doesn't work that well, doesn't change prognosis in ANCA vasculitis. So if I see this patient today, I probably wouldn't do plasma exchange as I did in 2015. And that's something in medicine, it evolves every single day. You learn something new. And you learn that certain practices that you did last year may not be relevant this year because you get new literature that says that may not be right. Right? Okay, I'll stop here. I hope it wasn't boring. Any questions? Okay. Stop it. Oh, sorry, sorry. Oh, code, okay. I just, you can take this.
Oh, yeah.
Oh, I think you need to.